This video talks about the coagulation cascade right from the beginning. So let's imagine that these are the endothelial cells. The pink arrows are the exposed collagen after the destruction of the endothelial cells or disruption of the endothelial cells, and this is just the continuation of the endothelial cells. So three things happen when collagen is exposed. Collagen is going to stimulate both the intrinsic and its extrinsic pathway. It's going to stimulate the intrinsic pathway by stimulating the Hagman factor or factor 12. So exposed collagen is going to stimulate factor 12, which is going to stimulate the progression of the intrinsic pathway. The exposed collagen is also going to release thromboplastin, and the thromboplastin is going to activate the extrinsic pathway as well. So imagine that the green line is the intrinsic pathway, the blue line is the extrinsic pathway, and this ashy, dark ashy line is the common pathway. So what happens is factor 12 is going to be activated by the exposed collagen, and the collagen is going to release thromboplastin, and thromboplastin is going to activate the intrinsic pathway. Now, what comprises the intrinsic pathway? The only thing that comprises the intrinsic pathway is factor 7 and the factors of the common pathway, and the factors that contributes to the intrinsic pathway are 12, 11, 9, and 8. These are the factors of the intrinsic pathway, and 10, 2, 1, and 13, these are part of the common pathway. Okay, so both the intrinsic and the extrinsic pathway is going to be activated by the exposed collagen. Another factor that can also activate our factor 7 is our tissue factor. Now, tissue factor is activated by trauma. Anytime there is trauma, which is right here, trauma is going to activate tissue factor, and tissue factor is going to activate factor 7, leading to the extrinsic pathway. So now let's summarize what are the factors of the extrinsic pathway and what are the factors of the intrinsic pathway. Just one more thing before we summarize is another factor we have, factor 5, which is also activating our factor 10. And factor 5 to factor 10, this is achieved by protein C. Protein C is usually bound to calmodulin. Now this is activated to protein C by protein S. Now protein S not only activates protein C, it activates protein 8 and protein 5. Okay, all these factors are activated by protein S. So now let's summarize all the factors of the extrinsic and the intrinsic pathway. So let's say intrinsic pathway factors are 12, 11, 9, 8, 10, 2, 1. 12, 11, 9, 8, 10, 5, 2, 1. 5 is also there. And for the extrinsic pathway, it's also going to be 7, 5, 10, 2, 1. 7, 5, 10, 2, 1. That's all I have written down here. Now, don't mix the PT factors 2, 7, 9, 10 with the intrinsic and the extrinsic. It shares both the intrinsic and the extrinsic factors. So whenever we are doing PT and PTT tests, or whenever we are using warfarin and heparin, both PT and PTT is going to be increased in both the cases. But in warfarin, we're going to have PTT increase more than PTT. In heparin, PTT is going to be increased more than PT. So it has nothing to do with the intrinsic and the extrinsic pathway. It has to do with which are vitamin K factors, which are 2, 7, 19, and CNS, which is understood by the PT. Measuring the PT. It has nothing to do with the extrinsic and the intrinsic coagulation factor. So what else is happening here? There's also something called high molecular weight kininogen. High molecular weight kininogen is making bradykinin. High molecular weight kininogen is also activating factor 12. Okay, it's also activating factor 12. Factor 12 in turn converts this enzyme. So factor 12 is going to come here and convert prokallikrein to kallikrein. Okay? Now kallikrein is then in turn going to activate more conversion of humomolecular weight kininogen to bradykinin. Okay, this conversion is going to go on even more. Now, what else is happening with bradykinin? Bradykinin is going to increase vascular permeability, is going to cause vasodilation, is going to cause more pain. Okay, so these are going to be achieved by bradykinin. And what about kininogen? Kininogen is going to go and activate plasminogen to plasmin. Okay, it's going to activate plasminogen to plasmin. This is going to be activated by kininogen. Plasmin is going to activate C3A. It's also going to go and activate fibrin degradation products. Okay, it's also going to activate fibrin degradation products, which is going to be seen in D-dimer test or assay. So that's that. That is all I have to say about the coagulation cascade. So now let's talk about platelets. Imagine this is a platelet and this is a platelet. And what happens is whenever there is exposed collagen, platelets is going to come and bind to that collagen. Okay, so imagine that the collagen part, this dark region, let's say this is the collagen. The collagen is going to bind to our platelet through a receptor. Okay, and we're going to call that receptor glycoprotein 2B3A. Okay, now this platelet is also going to bind to von Willebrand factor. Okay, but von Willebrand factor is not going to be binding to collagen. Von Willebrand factor is actually going to bind to the endothelium. Okay, and it's going to bind to the endothelium. So, and this binding is achieved by to the von Willebrand factor. This is achieved by glycoprotein GP. Sorry, this is not a glycoprotein 2B3A. This is actually GP1A, and this is GP1B, which is binding to the collagen. Okay, so that's going to happen. Another thing is that platelet is going to start binding to another platelet through glycoprotein 2B3A. Okay, the platelet also has ADP receptors, and ADP receptors is in turn going to stimulate the binding of glycoprotein 2B3A, and this binding is happening through fibrinogen. Okay, this binding is happening through fibrinogen. So now let's talk about platelets a little bit. Once the collagen is exposed and once the intrinsic and the extrinsic pathway is activated, the collagen, the exposed collagen also binds our platelets. The binding of platelets is achieved by von Willebrand factor as well, right? This in turn is going to activate more and more platelet binding. When more platelet binds, there is going to be ADP activated. ADP is going to cause more and more platelet binding. When there is lots of platelet being bound, this is going to in turn cause the thromboxane A2 from being activated. And thromboxane A2 is going to cause even more binding because TXA2 is responsible for platelet aggregation. This forms the temporary plug. This temporary plug is going to be further stabilized by fibrin products through cross-linking. And fibrin products is going to be achieved by 2 getting converted to 13. So once we have fibrin products and we give, let's say, TPA, TPA is going to come and break it down. As a result, we're going to have fibrin split products. If we have fibrin split products, it's going to be seen in D-dimer assay, right? So imagine someone with a PE, or imagine someone who had a thrombus, is going to be TPA. TPA is inside the platelets. It's going to be released anyways, and it's going to try to make more and more D-dimers, which are fibrin split products. So if we do a D-dimer assay on pulmonary embolism patient or someone who has a thrombus, we should be able to see D dimers because TPA is automatically being released from the platelets, right? That's another layer of information on top of what we discussed. So now let's end our discussion with two things. Factor 5, Leiden deficiency. When we have factor 5 Leiden deficiency, that is when we have deficient protein C. This causes a hypercoagulable state. And hypercoagulable state is going to cause too much coagulation in the body. This is analogous to when we use warfarin alone before we using heparin. What happens is when it takes a little bit time for warfarin to reach therapeutic dose. So warfarin is going to inhibit vitamin K factors, which are these ones. So protein C is going to be inhibited. As a result, this in turn is going to cause hypercoagulable state. But if we use heparin before, it's going to coagulate, and it's already going to reach to an anticoagulant state. So once we use warfarin, even though it decreases protein C, it's not going to cause hypercoagulable state, a paradoxical hypercoagulable state. So that is all you need to know about coagulation cascade.